Okay, so good afternoon. Thank you for giving me this opportunity. My name is Chanika and I'm a PhD candidate. I'm here to outline the findings from an integrative review that was published in Nurse Education Practice earlier this year. So the underlying conception of feedback is that it is a process which helps the learner to learn. Feedback is essential for learning and has been extensively researched. Evaluative judgment, however, is a newer term and one that we could not explicitly find in nursing and midwifery literature. However, concepts associated with evaluative judgment, such as reflection, were obvious. Evaluative judgment capabilities have been found to support the transition process from being a student to an independent practitioner. So research in other healthcare disciplines have found when students use feedback beyond the immediate task, that there is opportunity for development of evaluative judgment capabilities. So we sought out to find if feedback could be used as a strategy to develop these evaluative judgment capabilities in nursing and midwifery students as well. So in the reviewed studies, feedback was conceptualised as information transmission, and an example of this was when students were given information about their performance or knowledge and when corrections were highlighted. Feedback as dialogue was when students were provided opportunities to engage in and discuss their feedback. Students found the main purpose of feedback was to help them learn and to avoid making the same mistakes repeatedly. Students found feedback confirmed and reassured their existing knowledge as well as it justifying their results. Feedback also supported the integration of theory and practice, and students said that feedback helped them to be better prepared for the clinical environment. Educators, peers, and patients were all identified as feedback sources in the reviewed studies, and students preferred feedback from educators as they were considered to be the experts, and their feedback was therefore highly valued compared to the other sources. Students reported that peer feedback was considered to be supportive and motivating. However, it was not as comprehensive, and at times they were unsure of the accuracy and quality of it. Feedback from patients, whether they were actual or simulated patients, was also very much valued by the students, as they found this feedback to be direct, task-specific, individualised and authentic. Written feedback was provided to students in rubrics, marking criteria and clinical frameworks. Students reported that written feedback was very informative than any other modes of feedback. Verbal feedback was perceived to be vague and less informative, and students were often unsure of how to apply verbal feedback to enhance their learning. Visual feedback was when students could see their performance through video recordings. They said it was insightful and impacted their learning as they could see the mistakes and errors themselves rather than being told they had done something incorrectly. Haptic or tactile feedback was not so common, yet it was found to be influential, especially when students were learning clinical skills such as venipuncture. Conceptions of evaluative judgment related to the students' ability to evaluate their own work and others' work, and to make interpretive judgments on their abilities. Evaluative judgment as reflection is identified when reflective practice helps students to assess their own knowledge and skills. Recognising quality was essential to evaluative judgment in the reviewed studies, and rubric standards, learning outcomes and competencies all help students to identify what this quality looked like. Evaluative judgment was also conceptualised as comparing themselves to others, and this was common during simulation where students often made sense of their own abilities whilst observing the others. The purpose of evaluative judgment were found to provide opportunity for personal growth, and this is when students recognised that their previous level of knowledge and they could recognise how much they had learned or grown. Evaluative judgment empowered students to be independent learners for the clinical environment, and they were also able to recognise how their learning was relevant to their profession. Students expressed they could see how specific knowledge or skills fit into the bigger picture for caring for a patient and could transfer their theoretical knowledge to practice. So in all the studies that we reviewed, there was an apparent relationship between feedback and evaluative judgment. However, in two of the studies, the findings were somewhat contradictory contradictory, suggesting that there was also no relationship between the concepts. So a relationship between these concepts were identified when within the context of student engagement, when learning experiences were perceived as meaningful by the student, there was evidence of reflection and the students were involved in self-assessment, generally against standards. And finally, when students demonstrated awareness of their knowledge discrepancy. So in summary, this review supported feedback. That feedback promotes the development of evaluative judgment in nursing and midwifery students as well. And we were able to compare our themes and our findings with broader higher education literature. Our two most important and original findings were that concepts of evaluative judgment exist as a process and an outcome in nursing and midwifery education, and feedback processes need to position the student actively for evaluative judgment capabilities to be developed. We recommend that further research is now needed to understand how different pedagogical strategies towards feedback can influence students' evaluative judgment development in clinical practice, and also if there's a relationship between students' demographics such as age and gender and education-related characteristics such as whether they're a mature age student or a high school leaver, and how this impacts their evaluative judgment development. Thank you.
Beautiful. So my name is Patrick Garland. I'm a final year medical student with the University of Newcastle. And I'm here presenting the findings of our MD research project, which we conducted in our third and penultimate, so our fourth year of the MD program. And my supervisors were Associate Professor Gilligan and Professor Joly. There were also other 7 medical students that conducted this survey over 2 years in 2 phases. But yeah, so this is a comparison between medical curricula in developing self-reported professional identities. So just a little bit of background. So there are a multitude of factors that influence this process, including the structure of the medical curriculum, the hidden curriculum, which is any influence or exposure often found at clinical placement, as well as a variety of any socio-cultural experiences. And it's been found that self-perceived professional identities that were misaligned to the clinician's actual skill can lead to increases in medical errors, such as prescribing errors and barriers to effective communication. So understanding why and how these form and the way that they do is really important, so that we, as health educators, can best manipulate the process to lead to better patient care, basically. So the rationale for this paper was, and it's been happening all over the country with the inception of the new MD course, many courses have now gone to a Doctor of Medicine, which is an AQF Masters 9, which requires a research component from a previous undergraduate bachelor's course, often a MBBS or a Bachelor of Medicine in the case of Newcastle. So we were presented with a really unique opportunity with the inception of the new course. It essentially allowed for a controlled cohort where most other modifiable factors such as kind of age or gender or previous employment in healthcare could be kept as a control, and therefore the only influence would have been the new curricula. So we wanted to evaluate the differences in professional identity formation and its process between the 2 year groups. So for the methods, so eligible participants were any final year medical students. In phase 1 of the study, this was conducted in 2020, and this represented 5th year medical students in the Bachelor of Medicine program. And in phase 2, this represented 5th year medical students in the Doctor of Medicine program in 2021. An online survey was used to collect data using something called the Osgood-Hofstadter Polarity Scale, which collected data such as participant demographics, which we collected participant demographics, and then also their view on the Osgood-Hofstadter Polarity Scale, such as self-image and the real versus ideal doctor across a range of adjectives, which I'll go through shortly. We also then invited participants to undergo focus groups, some qualitative data analysis, and recurrent core themes in their development. So these were the results from our study over the 2 years. So a total of 58 5th year MD medical students completed the survey, with 15 further going to focus groups. And this was in addition to the 53 5th year BMed students who completed the survey in 2020, 5 of whom further participated in focus groups. And across both the cohorts, this represented 25 to 30%. So it was actually really good response rate or from a random population, essentially, compared to a lot of other health surveys, which pitch around 10% often. So this was a comparison. So this was a chi-squared analysis, essentially detailing that largely both the cohorts were identical across all parameters. So things that we measured, so things such as gender, previous healthcare study, employment admission type, and whether the participant was born in Australia, were all identical. There was no chi-squared difference between them, meaning that we could try and perform a kind of a controlled analysis. So these were the results of the survey. So this is what I was mentioning with the Osgood-Hofstadter Polarity Scale. So essentially it's a Likert scale where you have an adjective and then what is proposed to be kind of the antonym or the other end of the spectrum for that adjective. So using things like indifferent versus understanding for a variety of adjectives, basically. So as we can see on this, largely the themes between the 2021 and the 2020 were actually quite identical between the ideal, the real, and the self doctor, essentially. There were a few differences though, which I'll go into just now. So for year group, so the BMed program perceived the ideal doctor as being more understanding, idealistic, and sensitive than their 2021 counterparts. The BMed cohort regarded the real doctor as being more selfless and sensitive as well. For other parameters besides year group, admission types, so rural students self-perceive themselves as more powerful than powerless, which is very interesting. And international students perceive themselves as more passive and cagier than all other admission types. Previous employment in healthcare, so those with previous experience felt themselves to be more thorough, friendly, and open. For the focus groups, there were 4 key themes that came up, and they were role models, practical experience, prior exposure, and socio-cultural background. And these were recurrent themes in not only the 2021, but also the 2020 focus groups. So most students reflected that both positive and negative role models were really important, and that it was important to model after positive behaviours and to neglect negative behaviours so that they weren't subjected to kind of the micro erosions that students feel can lead to an indifferent, insensitive clinician. Practical experience, so many final year students reflected on pivotal moments, particularly in final year, such as task delegation, doing things such as cannulation, clinical reviews, which catalysed their professional identity formation from the medical student into the medical professional. Prior exposure, so participants believe that previous exposure to the healthcare system may prepare them more professionally, in creating more empathy, in allowing them to communicate better with staff as well as the general public, as opposed to providing a true theoretical advantage. And socio-cultural background as well. So socio-cultural expectations, such as those from high socioeconomic families where there may be one or multiple doctors in the family, or those from certain cultures may drive impetus to study medicine. So just a reflection point. So whilst the students in the study were exposed theoretically to different medical curricula, the COVID-19 pandemic unfortunately homogenized the 2 curricula more than we would have liked. One of the discussion questions is actually the difference in curricula, so I'll explore in this more in the discussion. But COVID-19 was found to mean that respondents were more insecure about their future, and the students believe they weren't able to study their course by remote learning. So just to sum up, the qualitative and quantitative data from this study highlights the similarities and experiences surrounding identity formation, also illustrating that differences can emerge within such a short period of time in similar contexts. And that's my presentation. Thanks so much.
Thanks for that, Lynn. So I'm a senior lecturer in the Joint Medical Program, and I'm located in Peel Clinical School, which is a Department of Rural Health. And I'm presenting on behalf of a group that have been working on professionalism in the University of Newcastle's Joint Medical Program. So a busy slide, but just to put things in context, the Joint Medical Program is a collaborative between the Universities of Newcastle and New England, and staff and students are across the New South Wales footprint as shown. The MD is a 5-year undergraduate medical program, as we've heard, and it has had a cohort graduate now. The MD involves a revised spiral curriculum, which is illustrated above, and the course is divided into 3 distinct phases with longitudinal themes across that include science and scholarship, clinical practice, health societies and environment, and professional development. Professionalism runs throughout the 5 years. The 2021 Medical Deans Development working document that looked at the latest evidence around professionalism and how it is taught, developed and assessed in medical schools, was a paper that has been integral in the Joint Medical Programs review via MeritNet, which is our medical education unit, if you like, and a working group was set up to consider professionalism across the Joint Medical Program. This working group consists of academics and professional staff, along with students across the JMP footprint, and I'm currently the lead of that working group. So to let you know what we've done so far, so while professionalism is an integral and essential aspect of a clinician, as we know, articulating and understanding professionalism as a concept is quite challenging. The reasons are multifactorial, but include a lack of shared understanding, the impact of cultural relativism, and the dynamic nature of ideas surrounding professionalism and professional identity, particularly within a society that is ever changing. The working group membership from across the JMP was developed a discussion paper based on this current evidence. And in 2021, this was distributed to all academic staff, key professional staff, student leaders, and conjoint clinical staff via a survey with some suggested ways to interact with material. Advice, thoughts, comments were captured and reviewed, and over 163 of these were received. A compilation of this was presented to the executive. This enabled a mapping of professionalism within the MD curriculum as it currently stands, identifying both strengths and areas for development. At the same time, we undertook a rapid Delphi process to inform a consensus definition and the attributes of professionalism assessment on clinical placement. The executive has further supported professionalism work by funding a short project, which I'm currently directing. But we still have challenges. The challenges can be summarised as the syllabus or the curriculum, signposting, stakeholders, and a shared understanding. So having a curriculum that spans the phases, that has themes and disciplines within the JMP is quite challenging. The new course's formative years, as we've heard from Patrick, were impacted by COVID. And there's also been university staff restructuring, particularly at UON, which has resulted in certain vacancies within the JMP. And currently the professionalism development theme lead is vacant. Having teaching activities and learning moments signposted or clearly articulated is a body of work that the project's currently focusing on. This will enable a shared understanding of what the JMP expects and fosters in the professionalism realm. Like any medical program, we're intersecting with many stakeholders, and the JMP recognises that professionalism development does not happen in isolation. All these members make up the people that are affecting our students. A shared understanding of the professionalism curriculum is something that we're really aiming to achieve, and we'll be taking the curriculum framework on a roadshow shortly. As many academics know, a lot of the focus in courses is on remediation or lapses of professionalism or professionalism breaches, and this has formed a large part of the work that we're doing. We've been fortunate to have interactions with Professor Barnhorn, and we are informed by his work currently considering professionalism panels to manage significant breaches and assist in this remediation process. These panels aim to assist students to consider professionalism as a career-long requirement, a journey. We would then, with these panels, assist students to consider the lapses and how they may work towards professionalism improvements. Standardisation of approaches and encouraging a developmental approach to remediation is central to our group's vision for professionalism within the JMP. Ongoing work that still needs to be considered: the alignment of assessment of professionalism, its role, purpose and effect, because we all know that assessment drives learning. The option of longitudinally tracking, possibly an online portfolio to capture activities, reflections and assessments relating to professionalism across the 5 year student's journey. This portfolio would be held by students and allow for the development of professionalism to be owned by them, but seen by others. Consultations, remembering the JMP footprint is vast, are upcoming, as we've said, and roadshows are going to our various sites. These are opportunities for focus groups to discuss and interact with the curriculum, with input sought from all our stakeholders, our professional staff, students, academics, clinicians and conjoints. This collaborative approach aims to foster engagement with and formation of the JMP approach to professionalism. So recognising that similar work is obviously happening across other universities, I'm really keen to hear from and collaborate with others to inform the JMP's approach. Ultimately, we all hope to graduate doctors with moral attributes, standards of behaviour, practice and clinical competence that the community expects. Thank you.
Good afternoon, everyone. I'm Ruyi from Perth. I recently completed my PhD and I'm really excited to be able to share my findings with you all today. My work is rooted in the belief that effective collaboration between health professionals is essential to deliver client-centered care. But how effectively are students prepared to deliver such care? I sought answers to this question by exploring how healthcare students at Curtin Uni perceive their professional and interprofessional identities at various points from university entry to the end of their first year of work. I went about this work by measuring identity strengths in first and final year students using identity measures that I adapted and validated. And then I held further conversations with some final year students involved in interprofessional placements. And then as they graduated and entered the workforce, I then held further conversations with some of these grads throughout the year. And this is what I found. I found that professional and interprofessional identities are in constant interaction. They are related and they're in constant interaction. The interplay between both identities manifests as the way that students and grads choose to practice. Now, this choice would vary over time because their understanding of identities varied over time. So, for example, as you can see on the slide, students entered uni with high levels of both identities, but by the end of the year, and that was a year-long interprofessional program, we found a significant decrease in interprofessional identity, except in situations where students had positive perceptions of their own profession, as well as quality interprofessional experiences. A similar identity trajectory was noted in final year students, regardless of whether they did profession-specific placements only or a combination of profession-specific and interprofessional. So curious, I asked some final year students to chat about and draw their thoughts on how interprofessional placements might influence their identities. And this is what I got. From the drawings, we can see that there's no one way of understanding, representing, and explaining how identities guide practice. The drawings reinforce that finding that practice orientation is a choice. And many of the students that I spoke with said that the choice was often influenced by factors in their practice environment, like the attitudes of other health professionals or team dynamics, or whether there was space to work interprofessionally. What about with the grads? A similar story. They entered the workforce with both identities, but the first month in particular was spent building confidence, practicing as qualified professionals. And they told me, you know, Ruyi, I need to know what I've been employed to do. But as the confidence increased, that's when some grads started exploring ways to embed interprofessional ways of working, because central to it all is this innate desire to ensure that the care that they deliver was client-centered. And I think this is a really important point and finding here, this innate desire. And as I chatted with them, you know, with further conversations later on in the year, I found that this intrinsic innate desire manifests as the ability to read the room, identify barriers to practice, consider multiple perspectives, and adapt how they work within their role to ensure that the care they deliver is client-centered. So I conclude with 5 take-home messages. Number 1, identity is not an outcome of education. This may seem obvious, but especially in interprofessional literature, it just seems like the identity has been portrayed as an outcome of an interprofessional initiative. Rather, education should be seen as a vehicle to support students to modify their understanding of identities. Identities, as it was shown, is always present. It develops in a dynamic way. So it's about how we're supporting students to modify their understandings. Identities guide practice, but practice orientation is a choice. Therefore, we need to really teach the concept of identities and how they relate to practice, and context matters. So in addition to saying, can you take students on placement, I think it's important for unis and industry partners to work together to really support students' development of identities, and for staff to understand why it's important to be committed to an interprofessional approach of service delivery. Now, should an identity discourse be incorporated within the curriculum, I think that a learning outcome of this curriculum should be that students graduate knowing how to adapt practice to ensure on the fly, to ensure that the care provided is client-centered in any context. Thank you.